I think right now, for this to be one of the first immune therapies to show an improvement in survival, I think it will impact how patients will be treated, and certainly will open up the doors. I think some other interesting data that came out of this morning's presentation was that patients who were never smokers tended not to have as high of a response rate compared to patients who had previously smoked or were currently smoking. The response rate was nearly doubled in those patients who had a previous smoking history compared to patients who had never had a smoking history. That may equate to mutational burden of tumors. We think patients who've been exposed to smoke, and that if that's the cause of their tumor, they have a higher mutational base, and that was actually published by Dr. Rizvi and colleagues earlier in 2015 in Science. Well, I think the next steps is whether or not this will be approved for non-squamous cell histology. We know that it is now approved for patients with squamous cell histology. And then again, trying to broaden it. Not all patients respond, unfortunately, and in order to try to increase the response rate, many of us are studying whether or not we should combine this type of therapy with other experimental immunotherapies. Should we combine it with chemotherapy? Should we combine it with radiation therapy? Or do we need other therapies like vaccines, or even what we're working on at Johns Hopkins is using epigenetic therapy, a therapy that might upregulate certain genes that may predispose you to respond to this, but we'll see.